As the open heart, we're also touching on interventional techniques, which is really exciting. So it's like what's been highlighted really nicely today, candidacy is really important for who we choose, and the dogs just present later and they die faster. So the transapical edge-to-edge repair is Hongyu Medical have developed a device which is pictured. It's a handheld device. It's delivered transapically into a beating heart. We use fluoroscopy and transesophageal echo to guide deployment. And to date, this data is lacking, but the group out of Colorado State have probably done 80 to 90 clinical dogs, and they're really the leaders in this field. And so we're, using their experience to create our own. And so these are the first 30-something dogs that they did. They had a 97% success rate in deployment, no procedural deaths, and 94% of them survived till discharge. They had 5% non-fatal clamp events. So device detachment remains one of the most significant concerns. And so you can see the mitral clip, obviously transeptal, as you know, then the valve clamp in China in people has been used, and then the V clamp is what we're using, which is pictured there. And this is it's deployed and both arms go together to clamp the valve simultaneously. So the candidacy, we need severe mitral regurg, which is very similar. The mechanism, often these dogs do have functional component because they're presenting late. The anatomy is obviously very important too. We're trying to do the A2P2 clip, and the device availability is becoming more and more. So there's now 5, but we're ultimately basing that on the annular dimension. And so we measure that at the hinge points between the anterior posterior valves, and then sizing 2 millimeters smaller to put the device in. And obviously leaflet length is important. The posterior valve can be quite short, and we need that to be at least sort of 8 or 9 millimeters. And so I won't dwell on this too much. You all probably know, but we're, again, using very similar criteria to you for the dogs to determine mitral valve severity. This algorithm was put together from the Colorado team about, center experience with placing these devices and which candidates we're choosing, and they never fit beautifully into the ones you want, but it's a guide, and I won't go over it too much, but it's very similar to what Dr. Little presented before. So our team, there's about 14 people there. 2 are probably familiar to you. Sharon and Professor Muller came to help us, which is great. Sharon's been instrumental actually in bringing all this together, including today for us. Thank you. So 14 different people. It's a huge exercise to get everybody together. We took 4 of us to China to really train in this, and another trip to Colorado to watch what they're doing as well. And it finally came to fruition. This is a little example of our setup. So we've got the toe down the head end, patients in right lateral recumbency. Obviously, our chest shape is quite different. We're going to make a little mini thoracotomy onto the left side, anesthesia. And then once they pass the toe test and see if their anatomy is suitable, then we go ahead and clamp. So this is a little procedure that's nicely presented, which I thought I'd take from Colorado. So the procedure is transapical. The sheath is 16 French. Dogs seem to tolerate the transapical really well. And they have a little mesh ball that's being advanced there into the LA over the mitral apparatus. Don't worry about the bubbles. Our patients don't have to spell their names, so that we get away with that. You can see the toe guidance, the fluoro guidance, and then we're going to advance that sheath up over the valve. What's interesting is the nice part of when you actually reduce the mitral regurgitation is the heart rate seems to go down quite nicely. And so the actual device, it's got those 2 arms, the top arm, the bottom arm. We open the device up into the LA, and then we're essentially going to nuzzle it down. And so the bottom arms end up below the mitral valve. We kind of then put some pressure up to capture the valve. We do a soft clamp, which is when they start to touch each other, and then a hard clamp, which is where they tether it up, and then we release if we're happy. So the imaging is very similar to what you're used to, and that's for us getting our eyes and used to looking at both screens. And this is handheld. We're literally resting our hands on a towel, and so trying to get that axis point correct, rotation correct, is, I think, very tricky but exciting. And then when we deploy, we have to wait very steady and tell us from the echo team that we're doing the right thing. We've got enough leaflet, and then it looks like that picture in the end once it's deployed. So we've only done 2 cases. One was a Stephen King, one was a Disney. So the first one, we had a valve detachment and resulted in emergency left atrial decompression, which was a bit sad. It worked for a few days, and then we saw the detachment a couple of days later. And that patient ended up succumbing to azotemia and ARDS, unfortunately. And our second case did very well. So significant reduction in the MR, and the patient was clinically really thriving. So that was exciting. And I think a few other things on the horizon. This is just a pilot study put together, another transapical approach. 6 dogs, 4 dogs survived till day 30, experimental dogs of a caudal implantation device. And some other things, left atrial decompression has been published. We've done a few of these dogs now, and they actually do really well, just shunting the blood to the right side. And some of the future perspectives, 7.5% of dogs that present to vets actually have mitral regurgitation. So it's really, really common. And they've got a short lifespan. It's a really good large animal model with naturally occurring disease, and that's really nice that we can collaborate with you and see what the future holds. So whether it's smaller mitral clips or others, we'll see where it takes us. So thank you.
Thank you very much, and bang on